and welcome to the Probe Dental Podcast. Today we're joined by Chief Dental Officer for England, Jason Wong. We're here to discuss the reforms that come into effect from April 1st, which, depending on when you're watching or listening to this, may or may not have already come into effect. Jason, thank you so much for joining us today. How are you?
Hi there, James. Yeah, good. Thank you very much. And hopefully we can get some information out there that will help people realise what's coming down the track.
Brilliant. Well, we wanted to start off by discussing the reforms introduce fixed tariffs for complex treatments and urgent care. So it moves away from kind of the pure volume-based UDA system. For the profession, obviously they've been dictated by UDAs now for almost 20 years in the NHS. Does April mark the beginning of the end of the current contract?
I mean, not necessarily the beginning of the end. You could argue that the 22 reforms changed that a little bit as well, because obviously the UDA contract was set against the 3 bands and extra sort of sub-bands were brought in order to recognise certain pieces of work. This particular reform that we're bringing could be seen as just a continuation of that and trying to push things, moving things in the right direction. You mentioned about, the profession being used to UDAs now for almost 20 years, but I think the one consistent feedback was that they really don't like it. And so from our side, whenever we were trying to bring any reforms forwards, one of the things was to make sure that it, the way in which it's been viewed, it'll be viewed as fair. And actually moving away from that as the sort of currency for contracts.
So obviously a core part of the new package as well is the requirement for practices to deliver a minimum level of unscheduled or urgent care, supported by the new payment per treatment. So some are worried that this might eat into routine checkup slots, affecting prevention. Will this make it more difficult for practitioners to help sort of maintain their oral health? Obviously, I guess it could be seen as sort of going against the kind of prevention over cure, which kind of is often preached.
Yeah, well, actually, quite the opposite. So I think from one side, I think to look at the picture, and I was fortunate to speak to the London Confederation of LDC just a couple of days ago, and across the country, actually, the amount of contracts that are delivering right at the top level is actually not as high as we really like it to be. And one of the main issues I think we've had in dentistry, certainly in terms of contracts, is the fact that it's really difficult to articulate that we would like more funding, but actually we seem to not be able to spend the funding we already have. So I think that's something to keep in mind. But yes, there is this element that the move does prioritize certain areas, and there's also this mention about the recall. So if I take the urgent care tariff at first, the first thing to recognise, I think, is the fact that the flat fee for the tariff is significantly higher than what's been paid for urgent care band, of course, treatment right now. So that is reflecting fairly actually what's being carried out. And then the others is more about really prioritizing certain groups. So we knew that from feedback from practices, as well as what was reported back, was that practices were really reluctant to take on a new patient. And they were reluctant to take on new patient, perception that some of them come in with a really high needs, high complexity. So it was important for us to say, well, actually, we can't disadvantage those patients because they actually might well be the ones that with the most need as well. And so therefore, these pathways have been put in place so that one treats someone who comes in with a high level of decay, and the second comes in with both decay and periodontal disease, and then lastly is for aggressive sort of periodontal disease. So recognizing the time it takes, but built into these pathways an expectation that prevention will be delivered. The profession has been asking for prevention based contract, and also, so the advice being given to hopefully encourage behavioural change. So for those particular people entering the pathway, the prevention is actually really built into it. That is kind of almost the whole idea. I think where it's become controversial for parts of the profession is, are you trying to change how frequently we see patients, and you trying to force that through? Now, very clearly, and in this set, what we're trying to say is, look, I think everyone should have an eye on risk-based recall, and actually, that's good for profession, good for patients as well. And the idea is that if we can have a look and see whether we can improve on that, there is no sort of direct sort of sanctions if that didn't improve. We need to try and find out what are the issues, and it may be that there are much more risk factors out there than we think, that is stopping people from going out. Low risk patient being seen in a year, that kind of level. What we're absolutely not saying is that people now need to see everyone at a year or 2 years. That's not what it is. It's actually saying, look, we need to be mindful, as a profession, that risk-based recall is the right thing to do. And, for something that when the guidance came in 2003, I think it is about time we kind of adopt to it. That's older than the contract, and I do think, and for the periodontal disease, and some people say, are you trying to make it a bit too complex? Well, the Perio World brought this in 2014. The BSP S3 guidance, this is almost 5, 6, 7 years ago. So, we're not pushing the boundaries, and as I keep saying, we've not invented these pathways. Are what's the best evidence base at this time, and it's not something that's been invented. I do recognise that there is a bit of sort of change and adaptation to that, and that people who have not sort of changed the way that they practice to follow the current best practice may find it a bit of a change. But the whole idea is to incentivize. And the other thing I want to stress is there is no compulsion to put people on this pathway. Um, you know, and it was a very nice way to finish the conference I was at the other day when someone put their hand up. Can I just check with you? Is it the fact that someone comes with all these issues? I've taken care of their urgent care, and then I've said to them, actually, would you like this? Would you like to go on this pathway so that we can treat all the disease that I've just been able to spot in your mouth? And the patient says, no, my conscience is clear. And I was like, yeah, actually, that's not a bad way of putting it. The system is not forcing someone to put them through. So there's quite a lot of give in that, both that and the nice guidance. But I think for a profession, it's our professional duty to make sure we're doing the best we can in those areas.
Brilliant. Hopefully that's kind of allayed some fears there, if there are any remaining. Obviously, so we're seeing new incentives for dental nurses as well to apply fluoride varnish, and dental therapists are going to be taking on more complex roles as well. So with that in mind, you've spoken about the dual narrative of recruitment. So we have enough dentists, just not enough doing NHS work at the moment. So is this skills mix, is it sort of the push for skills mix, is it a strategy to kind of fill that recruitment gap, or is it about fundamentally changing the career pathway for DCPs going forward?
Yeah, I think not quite. So I know the narrative you've just mentioned. My narrative has been that actually we are still playing catch up in the sheer numbers of dentists. So if you look at us in comparator countries, especially the G7, population dentist to population ratio is very definitely we're on the lower end of that. Now, there are steps that we're going to take, and in fact, an announcement was made a few days ago that of the increase both in UK places and also the international workforce. Overall, what I am thinking about is, and we do have an active work stream, is we really do want to push on that skill mix agenda, both to improve recruitment, but actually to improve retention of both. Actually, most young dentists I speak to say, when I say, what do you want to do? I want to progress. by virtue of you wanting to progress, you need to pass on some of the simpler work to someone else in order you can progress and expand your expertise. And same with other members of the DCP groups. I know they really don't like that grouping, but if you can take each of the registrant groups, that actually increasing the scope in terms of within their scope, increasing what they do, actually will improve retention as well as recruitment into those areas. So I think that's quite a good good place to start in terms of doing that. And there's a real question what we want of the workforce of the future. Are we in the position of saying, actually, we do want a workforce that is, workforce-wise, 95% of NHS work was done by dentists as opposed to dental therapists, dental hygienists, and the clinical dental technician. Actually, it's really good news that's gone up to 10%. So since the 23 reforms, that's gone up. Now, a lot of that might be in lack of reporting in the first thing. I'm not suggesting actuality that's happened, but that's the stats that we have in terms of declaration. I just want to make sure people are not saying that I'm trying to claim that's the case. But for me, it's a lot more about teamwork than it is about direct access. And I keep making this point. Our conversations on skill mix is far too adversarial. I just, people say, are you replacing them? No, actually, I'm talking about how a whole team can work together, everyone to the level that they're comfortable with, to the maximum if they want to be at that level, and how that improves outcomes and also improves it for the workforce. There's no question, though, I said that, even if there wasn't a struggle with workforce numbers, I'd be advocating for the wider team participation and the increased use of skill mix. But with it in place, it's almost like a no-brainer. And I wrote that blog for the NHS in 2023 where I said, look, this is a team sport. And I keep referring to the fact that, it is a team sport. And we rarely operate without another member of the team with us. It's just how we work. So why don't we make it so that people can do things in the right place? And interestingly, in the pathways where there is a component of delivering prevention, there's a lot of inconsistencies when you talk to colleagues, what exactly that means. And some thinks that, low sugar and eat a bit of cheese. I heard someone say the other day, low sugar, bit of cheese, that's it. That's my prevention. That's delivered. But actually, some of us have to admit, and whenever I speak to dentists confidentially, they always say this. I say, are we actually the best people to deliver that prevention? Do we have the feel for it, the inkling for it, and the enthusiasm for it? I'm not sure we are the best in the dental team for. And there are other members of the dental team who could deliver that much better. Hygiene. Is the dentist the best person to provide the hygiene part, right? Let's be honest. So it is about that. It's not about a change in quality. We're wanting to actually deliver the same, if not enhance it. It is about teamwork. But I don't know why our conversations do keep going to that adversarial bit. But I've got an active work stream which has got lots of people that are taking part in. And I'm hoping that'll bring something up because, and again, going back to adaptation, we the dental therapists came into being in this country in 1963, something of that description. So, and the rest of the world, funnily enough, I get contact from, Canada bringing in an enhanced hygienist level, which is looking a lot like a dental therapist. Singapore are increasing the scope of dental therapists to be able to treat adults as well as children. So we've had a few decades head start on quite a few other countries, but we don't seem to have adapted to it. And I'm sure we'll find a reason for that, and that's what we really want to solve. But in the meantime, I'm just saying, I think we need to just think about it a bit differently.
Brilliant, that's fantastic. And obviously, as you mentioned earlier, kind of the current system was, I guess, set out in 2003. So obviously, we're much further into the 21st century now as well. And so, I wanted to ask you as well. So, the new complex care pathways for gum disease and multiple fillings designed to reward clinicians. So, obviously, if that's for the time-heavy work that they're doing. However, many practitioners are crunching the numbers and wondering, if the remuneration actually covers the chair time. So, what data can you share that would reassure perhaps a skeptical practice owner that these new pathways are, financially sustainable for them? If they're in a high street practice.
Well, I think the first thing to recognise, I think, is the fact that it is an enhancement of what we're currently paying if you were doing the same thing. So let's be clear. So it's a definite enhancement of what it is. The second part, the addition to that, is the delivery of prevention, looking at behavioural change, and then the review afterwards. Some would say there are things that probably would be expected of us anyway. That if someone came in with a high level of disease, you wouldn't necessarily just jump in to find exactly what the cause is, deal with that cause, and then not think about the aspect of what sort of started it all off in the first place. So I think that from a practice owner's perspective, as I said, if you look at the figures and look at the enhancement, they were worked out. So, for example, I think the carers pathway, even though we're moving away from UDAs, was worked out to about 8 UDAs rather than the 3 or the 5 that you get now, to give you some idea. Now, I do understand some people who say, look, it takes time to deliver prevention. As I said, we've probably got to settle what exactly that means. Yes, and then to review it. But isn't that a great opportunity to be using the rest of the team? I mean, virtually all of that. I mean, even actually the restorative part can be done by the dental therapist, but virtually everything else in terms of what, if you like, the complex pathway is asking in addition of, brings in an extended duty dental nurse and a dental therapist and a dental hygienist straight into play. So if you are a business owner and saying, look, how do I make these work? I've crunched the numbers. I would say probably have a look at that. And then secondly, just look at it in the cool light of day. Yes, of course, there are cost pressures. That's hasn't that always been thus, but nevertheless, I think it's again, it goes back to what I've been saying. It's definitely a step in the right direction. And at the end of the day, we've always asked that to be rewarded for delivering prevention and everything else, and that is the part that is extra on those pathways.
Excellent. I mean, I'm sure many are going to, most, if not, will be happy to hear this. And I mean, obviously, the reforms include the funding as well for annual appraisals and a quality improvement scheme. Mm-hmm. Do you believe these reforms are going to be enough to attract young dentists to the NHS rather than sort of directly to the private sector? I know obviously there's talk as well about, perhaps almost like a national service to the NHS for new graduates. But
yeah, I mean, I think it's slightly separate. So I think it's definitely a step, again, going back to the phrase, a step in the right direction. So I think it's huge news. I mean, it's not huge in terms of the financial part, but I think it's huge news that the NHS for dentistry, for the very first time ever, is going to be paying for quality improvement. I just think, we need to just pause a moment and say, actually, that's good news. I know I get a lot of feedback about the fact it's a set fee for a practice, and therefore, the ones in the smaller practices are much better off than the ones in the bigger practice. But actually, it is a process of saying, look, you need to do peer review and kind of look at what you do in order to do quality improvement. Interestingly, the people have also reacted to the topic that's been picked for the year one, which is the idea of let's have a look at recall. Let's compare with each other, think about what we should be doing. But it was in the cold light of day pretty obvious what to choose as a first off, considering the mood music around. So for me, I think it's about is that, and then in terms of the appraisal again. I mean, appraisals are kind of almost done as a matter of course if you're an employed member of staff, isn't it? You expect to have an appraisal if you're employed. You expect to have an appraisal if you are employed in a trust for a dentist, if you're working as an employed dental officer, that kind of thing. that is done. I think where it's really good is it recognises that these are quite often self-employed folks, and for professional development, it's actually quite a good thing to have that and someone offering to do that, and then be paid for it. And also, I was pleased that dental therapists, dental hygienists, recognised as clinicians within that space, also being paid for the appraisals as well. So, from my perspective, I think it was huge. Certainly, my role was largely on the quality side rather than the quantity side. I was really pleased with that inclusion.
Excellent. And finally, as a practicing dentist yourself, I was wondering, so when you're standing kind of at your chair, you're practicing Grantham on the 1st of April, first thing in the morning, how do these reforms change the way you treat your first patient of the day at 9 a.m.?
Yeah, I mean, good question. I would say um, the one probably immediate change would be you probably need to evaluate exactly how much of your working kind of year is devoted to the urgent care part. I think as a practice, a lot of people are feeding back actually. Some are feeding back actually the figure that's been set. The 8.2% is actually less than what they're currently doing. Some are saying it's more, but it wasn't intended to be this big stretchy target for people to hit. So we're very, very clear about that. So I think that makes a difference in that you are making a contribution to the unscheduled urgent care of the nation. I think that is important. In terms of the pathway, I just think should any dentist and the practice that has the capacity see a patient that needs to that presents with that level of disease, having helped the patient out of pain, it gives you the ability to say, well, actually, there is a pathway you can go through without worrying about how that impacts on the attainment of the UDAs and all the rest of it. So I think it will allow that aspect. And the other aspect is I'm sure it will start conversations between myself, the team, and everyone else that we probably wouldn't have had, in terms of the quality improvement and in terms of the appraisals. I think, suddenly, and most good practices have good relationships within it, the culture of the team. But actually, I think even those with a good culture will go, oh, actually, we probably need to think about whether we do some peer review to increase, the quality of what we give out, and then actually between practice owner and associate, what we're going to do in terms of for the appraisal for this year. I mean, we've always run, where my management team always speaks to all our associates about, every year, and then monitoring it, which is, what are your plans? What do you want to do? And then, are there things that we can do to support that throughout the year? So it kind of is the same as what we've always done. And then hopefully, actually, the other parts that we haven't talked about is we'll probably on Monday morning think about where any child that presents with high risk is not just presented with the fluoride varnish and increasing the frequency of that. That actually, now that it's been remunerated sort of properly in that, been included in a band 2, someone comes in with a high risk, child with previous decay, practices do not feel like they're somehow hampered and having to feed into financial costs in order to provide that. They can just know that this has been taken care of in terms of the fissure sealant. And I think the fluoride varnish one, I think, is really good. It suddenly builds into, can we bring the extended duty dental nurse, who's by far our biggest, well, the dental nursing registry group by far our biggest, can we start to bring them in to have times when they are placing the fluoride varnish for people in between their consultations, but also can we bring them in to do the dietary advice, the prevention, and the behavior change that is, that will lead to the rest of the pathway. So sort of from that perspective is good. I mean, the vast majority of the package are, even the quality improvement, is about an opt-in. It's about whether, practices want to opt in. Obviously with that and the care pathways and everything else, we hope people do opt into it and use it. And indeed, even the fissure sealants, we're sort of calling on the profession to look at the evidence base and place that in. Previously, I suppose we were asking them to do that and asking for altruism in which to place the fissure sealant. But at least now, we're saying actually you will be, properly remunerated for this, so that you can go on and treat the patient. So I think actually the vast majority of the package is not something that on day one you suddenly forced into doing something else. And you may or may not be aware that there's going to be two phases of it. The statutory instrument is going to go through two phases. So on the 1st of April itself, the urgent care will come in. We'll also start opening up for the dental nursing and the fissure sealants, and also for the quality improvement. But the second statutory instrument will probably go through in May and will probably take effect in about June time. That's the complex care pathway and the denture adjustments part.
Okay, brilliant. So it's not kind of hitting everybody in one go on the 1st of April.
No.
Excellent. So it sounds like overall, I guess if you would sum it up, it's hopefully taking away some of the, financial stress, needless financial stress, allowing clinicians to provide the best care they possibly can. Is that the overall aim?
Yeah. So it should be making it easier for the clinician to do the right thing. So we've always known that it's the right thing to look at prevention first, treat the acute problem, and then treat. So it's making it easier for that. And then the other components is there's a bit of reprioritization. Not going to try and pretend it's not. There's reprioritization of those with the greatest need, reprioritization of those with the urgent need, and then there's a little bit on the skill mix component, as I've said. And then often overlooked, I don't think it's an insignificant thing for the NHS to be rewarding quality improvement. It's taken us a while to get here.
Brilliant. Well, thank you for your time today, Jay. So we really appreciate it, and hopefully that's kind of clarified a few things if anybody was still a bit cloudy on any of the points. But thank you for joining us, and keep us posted on any further changes or reforms that may be coming.
All right, thanks very much.